Welcome, everyone, to the Henry Schein webinar series on COVID-19. I'm Dr. Gary Severance with Henry Schein, and it's my pleasure to wish everyone a Happy New Year and to welcome back Dr. David Reznik for his first webinar of the year on this subject. Today, he'll be addressing the virus, the vaccinations, and the variants. Welcome back, Dr. Reznik.
Thank you, Gary, as always. It's a pleasure to be back performing these webinars. We have a lot to cover today because a lot has happened since the last month before the holidays. I do that everyone had a safe and happy holiday season and New Year, but we have some issues that we must address. So where are we today with this COVID pandemic? And as everyone knows, if we turn on the television, the impact in certain parts of our country is overwhelming. We really need to continue the conversation about asymptomatic and pre-symptomatic spread because that's how the majority of transmission is occurring. People, when they don't know that they're sick and they're not wearing masks, they're not protecting others. And so we really need to be careful about that. Look at COVID-19 vaccine regulations for dentists. The American Dental Association Center for Professional Services has a wonderful tool that we can use. Discussion of the new variants and will that impact our vaccines that exist today, and then looking at down the road on what some of the newer vaccines or the ones that are later in development, I shouldn't really say newer because they've all started around the same time, what that vaccine will do and what is the differences between that vaccine and the ones that are available today. So again, let's get started with where we are as far as a country. If you look at the number of the daily new cases and you go back to September and you can see it's a little bit less than 50,000. It stays that way. And then October, a slight increase. November, we see a slight increase. Then we see what happened around Thanksgiving. And we see that around Thanksgiving time, the number of cases started to peak. And then around December, they continued because that's post-Thanksgiving into the holidays. And now we're truly over 250,000 cases a day in the United States. So we really are going, at this point, in the wrong direction. If you look at the cumulative cases as of January 9th, there were 21 million cases of COVID in the United States. That is a lot of people who we know have this infection. I am sure there are a lot of people who we don't know that have had this infection, who had a mild case of it, asymptomatic infection, and we haven't counted those. So in 5 U.S. states, the crushing numbers are killing our hospital systems. They truly are overwhelmed. I just got notice that our hospital was on diversion for a few hours yesterday because just the overwhelming number of people that are coming in. But the 5 worst hit states are scattered around the country, and I think that this changes. So what I'm trying to get across is not just where the worst of the epidemic or pandemic is, but even if you're in a quiet area, how important it is that we maintain those basic principles of hand washing, masking, and physical distancing. If you remember back to March of last year, I told you I did not like the term social distancing. We are social animals. We need to be with other people. We need to talk with other people. So this is what we can do to remain safe. But the 5 worst hit states at this point are Arizona, California. I don't think that you can turn on the television these days and not hear about what's going on in certain parts of California. Oklahoma, Rhode Island, and South Carolina. They're averaging the most cases per person. In November, the worst affected states were in the upper Midwest and Mountain West. Wisconsin had been the focus for its startling positivity rate, over 30% at one point, and its field hospitals were reopening. I can say in Georgia, we have opened the Georgia World Congress Center again for overflow of patients at the hospitals. These are milder cases where you don't need to be in a hospital, you don't need ventilation, but you still need advanced care. So we've actually opened the Georgia World Congress Center up again and just showing how that epidemic is hitting us, and we don't show up as one of the 5 worst states. But as soon as the cases started to decline in states like Wisconsin or in the Midwest, we saw increases in Indiana, Kansas, and Rhode Island. If you look at historical perspective of where we are, when we began this series in March of 2020, The world had about 219,000 cases. There were a little bit over 9,000 in the United States for a percentage of the world population of about 4.3%. If you look now, there are 90 million cases worldwide. We actually have updated information showing 22 million cases in the United States, and we're almost 25% of all of the documented cases. And I want to make that point clear. These are the documented cases that we're aware of. The United States reported 4,000 coronavirus-related deaths on January 8th of 21, the most deaths we've seen in a single day since the pandemic began last winter. So again, this is very serious. I always like to bring good news, and I guess the good news is that we have vaccines, and I expect to see these numbers start declining once we get our medical and dental professionals vaccinated and those over 65. It was the first time our country has actually seen over 4,000 deaths in a single day. The U.S. has reported more than 365,000 COVID-related deaths, again, by far the most in the world. But again, we are reporting data, and maybe other countries aren't reporting data quite as well as we are. The CDC is forecasting that there will be between 405 and 438,000 people who will have died from this pandemic as of January. So again, the most important thing we can do is protect ourselves, our families, our staffs, and ensure that we provide the safest dental visit, which is something that I know we're all interested in doing. The impact on hospital systems has just been remarkable. I sort of alluded to some of the situations we're having at my hospital. There are now more than 132,000 people hospitalized with COVID-19 in the U.S., more than were hospitalized at the peak of our spring and summer surges combined. So we really are at a crisis peak point at the present time. The record hospitalization levels are not evenly distributed, so that's why I'm trying to say you might be in an area of our country where you don't have a lot of cases right now. As hospitalizations in the Midwest and Mountain West have continued to fall, they have risen in California and across the entire south part of the United States. California remains a hot spot, with Los Angeles County reporting a COVID death every 10 minutes. Hospital space is scarce. San Joaquin Valley in Southern California reporting 0% capacity in their IC units, according to the California Department of Public Health. Overall, the state has reported 2.5 million cases and more than 28,000 deaths. And each life is precious. In Arizona, 670 people per million are hospitalized with COVID-19, more than in any other state. Nevada has the second highest per capita hospitalization rate, followed by Alabama. So you hear all these other states, you don't hear us talking about Georgia, but our ICUs are full in the Atlanta metro area. So just like we're talking about, this is hitting places all across the United States. So how is this actually happening? The CDC is still talking about asymptomatic spread that drives the majority of questions. So there was a study that was done, and the question was, what proportion of coronavirus disease is spread is associated with transmission of SARS-CoV-2 from person to person with no symptoms? And what they found, looking at analytical models, looking at multiple scenarios for the infectious period of the proportion of transmission for individuals who have never had symptoms, transmission from asymptomatic individuals was estimated to account for more than 1/2 of all transmission. So overall, transmission is coming from someone who feels just as good as you and I do today. Transmission by persons who are infected but do not have any symptoms can come from two different states. So we have the asymptomatic people who will never develop symptoms. They will just go through, have the disease, not show symptoms, maybe have an ache or a pain, and then, or, a little cough, and no big deal, and they're fine. And then you have pre-symptomatic people. So they're the ones that aren't showing symptoms yet, but will eventually develop symptoms and hopefully not end up in one of our hospital systems. Under a broad range of values for each of the assumptions that were made, at least 50% of the new SARS-CoV-2 infections were estimated to have originated from exposure to individuals with infection but without symptoms. So I've noticed a big change in my local area. Everyone now is wearing masks. That is a great advantage. I've seen an increase of hand sanitizer in public places. And all of those steps that we took way back in March and April and May, all the steps that we took as dental professionals with screening our patients before they come in, calling them and asking, do you have symptoms? Setting up our operations where we have enhanced infection control, extraoral vacuum systems, HEPA filtration, all the different things that we have put in place, and wearing N95 masks, and the fact that we've always taken infection control so seriously in the dental office has actually paid off, and we're doing really well in our offices. But we can do a little bit better, and that's by helping to educate our staff, our neighbors, our friends on the importance of getting vaccinated, because a lot of people will have this asymptomatic disease, they'll think they're fine, and they'll pass it on. And that's something we actually need to take seriously. The CDC came out with a statement that dental professionals should have access to the COVID vaccine prioritization in the first phase. And that is truly important. We are at risk. In March of 2020, I received a call from the chief medical officer of our hospital system who said, you will have to use an N95 mask on any aerosol generating procedure, and you will have to use eye protection. And this was literally before we were even beginning to take it seriously, that we were in that protective phase. So we have N95s, and remember we went through that whole discussion on making sure that you have appropriate N95s, so 3M models, there's different models that are out there, and that you get fit tested. If you change your N95 during the course of a period of time, if you have multiple N95s in your office, remember OSHA wants you to have everyone initially fit tested for that new N95. For people who have been fit tested under the emergency health problem that we're under today, you don't need to have it annually done. But for new N95s, like for instance, I have a new dental assistant on my staff. I had to send her to the hospital to get fitted for 2 different kinds of N95s that we're using in our program. So most dentists, and this is really good news, 64% of dentists said receiving the COVID vaccine is extremely important, and 20% say it's very important. So 84% of our dentist colleagues are really coming through and saying, yes, we need to get vaccinated, which is really a great number. We need to be at 100%. We need to make sure everybody gets vaccinated. But we also need to make sure that our staff buy in. When I first started realizing that we were going to have vaccines available, about 3 weeks before they were available, I asked my staff to fill out a little sticky, a Y for yes and an N for no. Would you take the vaccine if it were available? And the results that I got were 67% said no, and 33% said yes. So I did constant education over a period of those 3-week period of time, not dictating, just giving the information, saying and getting the vaccine myself. And basically what ended up happening is everyone but 4 individuals, so about 80%, 75% did get the vaccine, at least the first dose of the vaccine. I'm scheduled for my second dose on the 22nd, and I'm looking forward to telling you about any kind of symptoms that may have occurred for me and the 3 residents that were actually vaccinated on the same day, so we're all going together. I will tell you from the first vaccine shot, I had no symptoms whatsoever. I did hear about some arm soreness from the first shot, and that honestly is about it. And it was over in about 24 hours. So don't be afraid of the vaccines. Remember, we talked about the technology. mRNA vaccine technology is over 10 years old, and looking at coronavirus vaccinations has been taking place for almost 20 years. So it's great to know that our dentists are educated, but please concentrate on our dental hygiene staff. They're so at risk. And remember, we've taken special precautions for our hygienists as well, and our dental assistants, our front desk staff, anybody who comes in contact with patients. The Dimensions of Dental Hygiene by Kristen Pratt Machado. She reported that the CDC had confirmed that oral health professionals are included with other healthcare professionals in the first phase of COVID-19 vaccination rollout. and it was made based on input from the Advisory Committee on Immunization, which is an outside committee that advises the CDC. The ADA Center for Professional Services really did come up with a wonderful vaccine allocation and administration status for dentists in the United States. You can access this chart through the ADA, and all you need to do is click on your state and find out, one, where are the dentists set up to be vaccinated? Are they 1A, 1B, 1C? And are they able to help with vaccine inoculations? Which I think is absolutely wonderful. And it's a very proactive way of cementing that medical dental integrated model that we so talk about all the time. So the first state that I looked at, well, I went in alphabetical order, and the first state that actually came up was Alabama, my next door neighbor state. And if you look, they're in phase 1A. So they're at the top of the chart to get vaccinated. If you look at vaccine administration, can dentists currently administer the COVID-19 vaccine in Alabama? And the answer is yes. Regretfully, the answer for Georgia is not yes at this point, but something I'm working on. So then I looked at a state that's really having a huge problem right now, and that's California. Dentists can receive the vaccine. They're phase 1A, tier 3. California is one of our largest states, and they've tiered it out. Can dentists currently administer the COVID-19 vaccine if they've taken the required training? And that's important. It's not this that we're giving shots, but they're having a 4-step training program. And the answer is yes. Again, a wonderful model showing the integration of medical and dental. Then I went up to the Northeast. Let's take a look and see what's happening in New York. And again, phase 1. So all the dentists are in phase 1. And yes, with the proper training and approval, dentists can provide vaccinations in the state of New York. So when you think different parts of the country are acting in a very proactive manner to get dentists involved in vaccine distribution. There's also been money that's been allocated to the states now that will help states build up their capacity to provide these vaccinations. And actually now we've already changed some of our guidelines so that people who are 65 and older, who are at most risk for bad consequences from this disease, are able to get vaccinated. If you look at the WHO weekly epidemiological update, for the third week in a row, over 4 million new cases were reported globally, and new deaths increased by 3% to 76,000. The cumulative number is over 83 million reported cases. We talked about a bigger number, and over close to 2 million deaths globally since the start of this pandemic. There are different variants of this virus, and I think that makes people a little concerned. And so we're going to spend just a bit of time talking about them. As of January 5, 2021, the B.1.1.7 variant, initially detected in the United Kingdom, has been detected in 40 other countries, territories, and areas in 5 of the 6 WHO regions. The 501YV2 variant, initially detected in South Africa, is in 6 other countries, territories, and areas. And why is this important? Well, if you look at this graph, this is the daily new confirmed COVID-19 deaths per million people. It shows a rolling 7-day average. Limited testing and challenges that I've talked about early for the cause of death, makes this an estimate to a degree, and there might be more deaths from COVID-19 than we're actually reporting. And you can see on the 2 places that I've taken out on this record, the United Kingdom and South Africa. The United Kingdom saw a great deal of deaths in the March and April time period, and then, as you can see, the graph went down and stayed very low in August and September, started to rise in November, and as of January, you can see the arrow is pointing up. The same thing for South Africa, except they haven't been hit as hard. Their death rate was a little bit higher in the August area, stayed down in September and November, but when you look at January, you can see the increased number of deaths per million. Again, this is due to their new, more contagious, but not more virulent. So it's more contagious, but it does not make you sicker, but more people are getting it. With more people getting this disease, more people are dying. So what's special about these variants? All viruses mutate. When you think about the flu, we get a different flu vaccine every year because that virus mutates. And HIV disease, this retrovirus mutates based on the drugs it's exposed to. And there are a lot of mutations that mean nothing. I mean, we see mutations all the time, and they're just mutations and they go away. It doesn't make the disease more worrisome or more contagious. Mutations are just part of nature. And so as viruses mutate, they move through populations. Until recently, they weren't a cause for concern. We would see lots of these mutations, and we have different ways of tracking them, and it really didn't make a big difference. But the B117 in the UK and the 501YV2 in South Africa each have a lot of changes in the virus's spike protein. That's the part that we're looking at our vaccines to prevent transmission. And so that's the part that actually fits into the human cells, allowing it to infect folks. Scientists say they now be driving some of the stunning case growths that I just talked about in the UK and South Africa, forcing new, tougher control measures. And as you may be aware, the UK is presently under lockdown. The super strains could disrupt our life again just because it's more infective. And that's why just following those basic guidelines that were given over a year ago will truly help us stay safe and healthy. They make the virus, these changes make the virus more contagious than earlier versions of what we know is an already contagious virus. There is no evidence that these variants cause a more severe disease, meaning more cases are further stressing out our hospital systems, and after that, a rising death rate. The UK variant contains 23 mutations, so it's just not one mutation, it's 23 mutations in the genome of the virus, while the South African variant has at least 21 mutations with some overlap between the two. In both cases, the changes seem to have increased the fitness of the virus or its ability to replicate. Again, it does not make a more severe disease, it just makes it more contagious, which is while maintaining all of those extra precautions that we're doing in the dental setting remain vitally important. Make sure that we have clean N95s on, face shields on, eye protection on, disposable gowns on, and all of the devices that technology has created that are available to us. Don't just think this is going to be here today and gone tomorrow. 2021 is going to be hopefully a better year as more people get vaccinated, but there's still going to be people who will not get vaccinated. At this point in my hospital, only 30% are vaccinated. So there are a lot of people, frontline workers, who still aren't vaccinated, and there's a lot of doubt about the vaccines. And that's part of our role, is to help educate people on the benefits of the vaccine, as well as what might be a risk that you'll take, that you might have a soreness or maybe have a fever on the second dose. The Pfizer BioNTech vaccine appears to be effective against these new coronavirus variants. So Pfizer reported that the vaccine was able to protect against a key mutation in the variants discovered from both the UK and both South Africa. So that's actually great news. The study was actually done by Pfizer and scientists from the University of Texas Medical Branch, which has not yet been peer reviewed, but we've got a lot of information coming out. And when something is as important as this, we really do need to get this information out as soon as possible. But their study indicated the vaccine was effective in neutralizing virus with the so-called N501Y mutation of the spike protein, which is what's making it more contagious. It's truly important that we do constant monitoring. So U.S. researchers plan to run similar tests to see whether the vaccine protects against other variants as they occur, other mutations as they occur, and they hope to have data quickly so we can make adjustments. That's one of the great benefits about the mRNA vaccines, is that you can actually change them in a very quick fashion. It's not like growing something or looking in a year in advance. We can actually change these vaccines pretty quickly. The variants are said by the scientists, again, to be more transmittable than the initial dominant one, but not thought to cause more severe illness. Do we have these variants in the United States? A case of the UK coronavirus variant was reported in my home state of Georgia. The first case was detected in an 18-year-old man with absolutely no travel history, reports the Georgia Department of Public Health. It's the fifth known state to report a case of the variant at the time of this recording, following New York, California, Florida, and Colorado. Is there an impact on the effectiveness of the emergency use authorization vaccines in the U.S.? The current available vaccines that we have, and that's Pfizer, BioNTech, and Moderna, help the immune system target multiple areas of the spike protein. So we're not just looking at one area, they're literally trying to cover multiple areas of the spike protein. So the virus would have to change dramatically to totally escape the immune response that's produced by these two vaccines. The odds of having a variant that is going to be immune to our present vaccines is unlikely, but not impossible. So in all honesty, we're just giving this information to show that, yes, let's get the vaccine. If there is a problem when we have a new variant, we might have to get another vaccine next year. One of the issues that we don't know is how long do these vaccines actually protect? And so we have some data now showing that that we do have a bit of protection that goes on for about 8 months, but we really don't have any longer data at this point. So that's something we need to keep an eye out for. How often will we have to be vaccinated? Will it be once a year, once every 2 years? Would it be, apparently it's not going to be like getting measles, mumps, and rubella where you just get it once, or polio where you get it once. About 5.1 million Americans have received their first dose of COVID-19, which is just 1.5%, which is why you're seeing changes in how the administration is handling vaccine distribution. The U.S. could soon administer more than 1 million vaccines daily, and that would be great. At present, the nation is giving only about 500,000 doses each day. The nation's first healthcare providers to receive COVID vaccine are now getting their second dose. So we have people who are getting their second dose out of the study environment. Sandra Lindsay, the critical care nurse in New York City, who was the first American to get vaccinated on December 14th, did get her second dose on January 4th. So the administration actually has announced some sweeping changes to its administration vaccine rollout this week, including making all coronavirus vaccine supply immediately available. We were holding back a certain amount because, and this is actually something worth discussing. The UK is trying to get everybody at least one dose because they're at such a crisis right now. And the United States, what we were trying to do was to say, if you get your vaccine, your Moderna vaccine, then 21 days or so later, we're going to make sure we have a vaccine available for you. Pfizer, BioNTech, it's the same thing. If you got your, Moderna's 28 days. If you got your Pfizer vaccine, then it's about 21 days later. And so we wanted to make sure that second dose was available. Now, we're just trying to make sure in our hospital system, in our infectious disease colleagues, and those I know in vaccine research, we really want to make sure that you do get that second dose because that's how we know the vaccines are effective. That's what the studies were based on. But based on limited uptake and the fact that when we don't want to throw out any of this vaccine, that we have as a country opened this up to those who are most vulnerable, and that's healthcare workers, first responders, and people who are 65 years of age and older. So the common questions, and let me go over it again, Pfizer's 21 days or so. I'm not getting my second dose exactly on 21 days. I believe it's 23 days because I'm getting my second dose on a Friday. About 25% of folks will show a great immune response. And basically that means just besides a little soreness in your shoulder, you might get muscle aches, you might run a low-grade fever, you might feel flu-like symptoms for 24 hours and it'll go away. And that's about 25% or so. What we're doing is trying to we want people to come back into work as long as they don't have a fever greater than 101. And we really don't want people just calling out because they have aches and pains. And so that's just some of the things we want to know about the second shot. So there is no live virus. And none of the vaccines that I've talked about today or previously or will talk about, do they contain live virus? You cannot get COVID-19 from getting the vaccine. It's not possible. And there is a great deal of hesitancy on people getting the vaccine. You will see lines of people lining up as we go into a bit of a mass vaccination effort. But there are a lot of people who live in the United States who have hesitancy because this was developed so quickly. That's why it's up to each of us in our own practice, in our own environments, and our own communities to really try to get facts out there and not depend on hearsay or I'm afraid or whatever. We really just need to be constantly saying this is a great thing to do. You were vaccinated as a child on different illnesses, and these vaccines will help you stay healthy, help your family, your patient practice stay healthy, and keep your businesses thriving. So how does the new AstraZeneca COVID vaccine compare to Pfizer's and Moderna's? This has actually already been approved for emergency use in the UK, in India, and in Mexico. Unlike the Moderna and Pfizer vaccines, this is a modified version of the common cold virus or adenovirus that spreads among chimpanzees. This is the first vaccine of its kind to be approved for human use, but other companies are developing similar tech to fight COVID-19. It was developed by Oxford University and the biopharmaceutical company AstraZeneca, and it could be a way that we're actually going to get vaccine to the rural areas of our country, the more frontier areas of our country, and of course, rural areas and underdeveloped places around the world. Unlike its competitors, the AstraZeneca vaccine can be stored at much higher temperatures. It costs a lot less per dose and uses a different technology to immunize people. As I mentioned, the AstraZeneca vaccine uses an adenovirus vector technology or the common cold, but not for humans, for chimpanzees. It's a modified version of the cold vaccine. It can't make you sick. Again, I want to stress that none of these vaccines can make you sick, but it does carry a gene from the novel coronavirus's spike proteins, the portion of the virus that triggers an immune response. This allows the immune system to manufacture antibodies that work against SARS-CoV-2 and allows your body to respond should you become infected. So how do they compare? The Pfizer and Moderna vaccines rely on mRNA technology. Again, it's relatively new. It's only 10 years old. Introduces a piece of genetic code that tricks the body into producing COVID-19 antibodies. No virus required. All three vaccines require 2 shots spaced about a month apart. There are significant differences in storage. The AstraZeneca virus AZT1222 can be stored for up to 6 months at normal refrigerator temperatures. That's a whole lot better than the Moderna and Pfizer options, which must be stored at sub-zero temperatures until they're ready to be used, at -4 for Moderna and -94 for Pfizer. mRNA technology is relatively fragile compared to the adenovirus vector tech, meaning it must be kept at a lower temperature. The estimated cost, and as you know, we're giving vaccine for free in the United States, but there is an estimated cost. AstraZeneca's vaccine cost providers are about $4 a dose. Pfizer's cost about $20 a dose, and Moderna's cost about $33. So those are pretty significant numbers that we're showing. Efficacy, Pfizer and Moderna report about being 95% effective against COVID-19 after the second shot in clinical trials. And again, I really am opposed to anything bearing off of our clinical trials because those are evidence-based research, as are my colleagues who really think we should follow the data that was presented in the research trials to get this emergency use authorization in the United States. AstraZeneca has reported an average efficacy of 70% and up to 90% if the dosing is adjusted. So is this virus worthwhile, and why is that 70% number? Well, first, let's talk about the annual flu vaccine, which is only about 40 to 60% effective. And so the flu vaccine, again, doesn't cause the flu, which a lot of people have this mystery concept that it causes the flu. It does not. It does not have live flu in there. But why are the AstraZeneca numbers looking a little bit different? And what might you hear? Well, there were two different regimens that were used in the study. One dosing regimen that had over 2,700 people showed vaccine effectively if their first dose was a half dose followed by a full dose about a month apart. Another regimen that they used that had more people in the study, closer to 9,000, only showed 62% efficacy when given as two full doses a month apart. So literally more was not better. So the half dose given on the first, followed by the full dose on the second, was about 90% effective. No hospitalizations or severe cases of COVID-19 in participants treated with AstraZeneca's vaccine. The side effects? Basically, all three vaccine side effects are similar. You might have potential injection site pain. That is the case with almost all injection materials that are given. After the second dose, you might get flu-like symptoms, which you talked about, including fever, fatigue, headaches, and muscle pain. And this is actually the result of your immune system doing what it needs to do and showing that it's primed, that if you are exposed to coronavirus, it's going to do what it needs to do. Which vaccine is the best? Well, we really don't have a choice at my hospital. We're either getting Moderna or Pfizer based on availability, what we have. Would I make a selection on which one I want? No way. I'm following the data. I have full trust in an Emory School of Medicine's infectious disease folks and their research folks that were involved in some of these trials. So there really is no best option at the time, and there's not enough research to confirm that yet. Vaccines are not a silver bullet. Once you're vaccinated, you really need to still combine that with wearing your masks, hand washing for 20 seconds, and physical distancing to work as effectively as possible per the CDC. Can you still get infected with COVID-19 after being vaccinated? So on December 18th, a San Diego emergency room nurse was given a shot of the COVID-19 vaccine. A week later, he tested positive for the virus. So why did this occur? Immunity does not kick in right away, and this individual had only received shot one. It takes time for vaccines to build up immunity, and the two presently authorized coronavirus vaccine both require that second dose, given several weeks apart to train the body's immune system. People can be exposed to coronavirus right before being vaccinated or right after, and there won't be the time for the body to develop its defenses. The 95% efficacy number for COVID-19 vaccines assume that there's some built-in wait time. Moderna measured the efficacy of its vaccine starting at 14 days after the second dose, while Pfizer measured 7 days after the second dose. So I think it's important to realize that you still only have 95% protection. So there is a 5% chance. 5% chance is more than I'm willing to take. So when I go if after I get my second dose and say 10 days later, I don't feel like Superman. I feel like someone that's going to wear a mask when I go to the grocery store, that's going to be wearing a mask when I'm in a closed environment, that will still be doing a lot of takeout. And so we don't have silver protection. We don't become superhuman and immune, completely immune. But there should be a remarkable drop in hospitalizations, a remarkable drop in deaths. But it's, again, up to us to try to convince not just those we work with and not just maybe our patients, but those in our communities, those in our religious affiliations, those in other groups that we may have, the importance of getting vaccinated. No vaccine is 100% effective. The makers of coronavirus vaccines are still evaluating whether the shots protect against all infections or just those that cause symptoms. So we don't know about asymptomatic infection. The CDC estimated, as I said, 40% of coronavirus infections don't cause symptoms, and the trials of both Moderna and Pfizer BioNTech vaccines looked only at whether vaccines prevented symptomatic infections. So there's a difference. We don't know if it prevented asymptomatic infections. We do know that it prevented symptomatic infections up to 95%. Moderna said in its December report it had submitted data to the US FDA showing that vaccines prevented 2/3 of all infections, including asymptomatic infections. For now, the CDC recommends that people not assume that they are completely immune to infection after having been vaccinated. So it truly is important for us to continue to follow those CDC guidelines and ADA recommendations, look at OSAP for further information, look at different sources, but it's important that we have unanswered questions. Vaccinated people still need to use all tools available to them. And our general settings, again, if every staff member is protected and all your patients say they've had both shots, still use all those recommended tools that we have to ensure we have a clean air environment, that we have no suction, that we have no splatter and aerosol drifting through our programs. We have devices, we have technology now, we have pre-rinses that are available that are in use. We are aware that we have we are aware we have vaccines now. We are aware we have this awful pandemic that's impacting our world. I'd like to end with some good news, and the good news is that vaccines are available. The good news is that if we take steps, we take the personal responsibility to wear masks, to get vaccinated, to wash our hands, to do all of those things necessary to protect ourselves and our loved ones, there will be a light at the end of this tunnel. And with that, I'd like to pass it back to Gary. As always, it's always an honor to have this time to speak with you, and I look forward to speaking to you in the future. Thank you.
Thank you, Dr. Reznik, for the needed update. As always, we appreciate your special insight and direction. If you have any questions, concerns, or topics for upcoming webinars, please let us know by sending an email to webinars@henryschein.com. And please subscribe to our YouTube page by clicking the subscribe button below. We're back on our regular schedule, so until we see you again, stay safe and stay informed.